This video theater will cover the advantages and techniques used in the minimally invasive management of Hallux Rigidus. Disclosures for the authors of this presentation are shown here. Hallux Rigidus presents as degenerative arthritis of the first MTP joint. It has a prevalence of 2.5% in patients over the age of 50 and can be treated with both conservative and surgical intervention. Non-operative management includes use of NSAIDs, activity modification, orthoses, and injections. Hallux Rigidus is classified as Coughlin and Chernus grades 1 through 4 in severity based on radiographic findings and physical examination. Operative considerations for managing this condition fall into a few categories. Possible surgical interventions include open cheilectomy along with molar osteotomy in more severe cases with higher grade lesions. Fusion is effective in higher grade lesions, but patients often prefer to preserve the joint. Arthroscopic techniques are emerging for cheilectomy as a less invasive alternative, which are often associated with shorter recovery and fewer complications when compared to open surgery. In this case, the patient was a 59-year-old male who reported to clinic for evaluation of his left hallux. He'd been experiencing pain for 3 months prior and had no known injury to the joint. He complained primarily of pressure and discomfort while wearing shoes, as well as sharp pain after prolonged walking barefoot. In a prior visit with urgent care, he was assessed to have bone spurs of the first MTP joint. He did have a previously successful cheilectomy on the contralateral side, which was done using an open approach. He works as a contractor and was very concerned over having a similarly lengthy recovery time, as his work is physically demanding and he did not want to be out for a long period of time. The diagnosis here is left hallux rigidus, grade 2. Here we see a comparison between pre-op radiographs from two angles which demonstrated arthritis of that first MTP joint. Note the sclerosis and spurs along the dorsal edge of the joint. We compare this to the post-op X-ray seen on the right here. Arthroscopic intervention included cheilectomy and debridement.
This is our operative setup for hallux arthroscopy. This is a left foot. We have to our left is the mini C-arm, which we'll use at the end to confirm adequate resection of the spurs. I have the screen on my right side here. Notice the screen's at the foot of the bed, which is unusual for arthroscopy, but given the alignment of the surgeon to the foot, it's helpful to have the screen down at the end of the bed. And we'll go ahead and get started.
This procedure will use dorsomedial and dorsolateral portals to access the joint. Here we can see the associated landmarks. Note the positioning of the dorsomedial and dorsolateral helical nerves, which are the most at risk for these portal locations.
With an 11 blade, I'm going to make my incision. We're using neck and spread technique, so I'm cutting through the skin alone. I'm going to take my shaver and actually start by just keeping it outside of it. But I want to try and create a little bit of a plane from inside the joint out, and with the goal of just trying to increase my space, my working space, before I actually get started. 2.9 scope. Think of a smaller scopes just gives a smaller field of view, and the smaller scopes tend to bend and break more easily. So my preference is to use a my second portal, establishing it under direct visualization. I can feel it dropping into the joint, so I know the level is good, and I can also see it arthroscopically.
Early in the debridement process, the goal is to identify the margins of the articular surfaces and expose the spurs. Here we are looking at the dorsal aspect of the joint. We will debride loose and degenerated tissue in part to create space so that we can burr down osteophytes on the head. Here we are coming over the prominence of the metatarsal head. What we can see here is the majority of the dorsal osteophyte that we will resect. Coming down in an anterior direction, we see cartilage that appears to be preserved. Underneath here, we see the head of the proximal phalanx, which appears to be mostly preserved as well. Located deep in the screen here, we see the more plantar aspect of the metatarsal head and the proximal phalanx, both of which have intact cartilage. The more dorsal aspect, which is currently closer in the screen, is where we see full thickness cartilage loss. Here we are using a 3.5 hooded oval burr to resect the dorsal osteophyte. It is important to have released the overlying soft tissues as noted at the beginning of the procedure in order to visualize this plane. We maintain a constant plane across the surface of the spur in order to resect smoothly across the breadth of the spur, in order to prevent gouging and excessive points of penetration. As the resection continues, the space continues to open and the resection becomes easier to visualize and perform. Here we are dorsiflexing the hallux, which permits increased access to the dorsomedial aspect of the joint, allowing us to see the corner of the metatarsal head just a little bit better. As we look across here, we can see that it is slightly more prominent than the rest of the bone, so we will burr more. We consider the same precautions with burring that we did before, maintaining a constant plane across the surface of the spur in order to resect smoothly and prevent gouging. Here we have located the bone spur on the proximal phalanx identified by X-ray, and will burr it down. Bone spurs are often easier to burr through than healthy bone, so this can be an indication that you're in the right area if it burrs easily.
I palpate and just to feel for any prominences here. I feel the medial side of the bone, but not the dorsal prominence. The normal medial side is palpable. Dorsal prominence is certainly eliminated. We can check dorsiflexion like we would do in an open. I generally haven't tried to get as much dorsiflexion as I would in the open because I think it tends to scar less, which is part of the limitations with the open procedure with ultimate range of motion. But that shows us our dorsiflexion here. Plantar flexion.
As shown before, X-ray radiographs from a lateral view demonstrate successful resection of bone spurs in the affected joint. The patient is currently 6 weeks post-op and has been experiencing steady progression in his recovery with minimal pain. Outcomes for arthroscopic intervention in Hallux Rigidus are shown here. A 2020 study of 36 patients reported 84% of patients had little or no pain, with 0 patients requiring fusion down the line. A study from 1999 states no or minimal pain for all 12 patients reviewed at about 19 months post-op, while an earlier study from 1988 reported pain relief in all patients but only partial for 33% of those at a mean follow-up of 9.4 months. In conclusion, we have demonstrated here an alternative to open cheilectomy in the treatment of Hallux rigidus. Due to the small size of the joint, it is a challenging procedure and does require a high amount of technical skill. Additionally, in our experience, this surgical technique has shown reduced recovery duration, complications, and early postoperative pain as reported by patients when compared with the open procedure. Thanks for watching. Feel free to contact us with questions.